Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing Alzheimer's disease. On previous episodes of Well Said, we've discussed other neurological conditions, but it's probably safe to say that few conditions cause as much fear and widespread human suffering as Alzheimer's disease. To help sort out the latest information about Alzheimer's disease, my guests are my colleagues Dr. Marzena Gieniusz and Dr. Luca Giliberto. Dr. Gieniusz is a geriatrician and directs the Alzheimer's and Dementia Care Program at Northwell Health. She's also an assistant professor at the Zucker School of Medicine. Dr. Giliberto is an attending neurologist at the Institute for Neurology and Neurosurgery at Northwell Health and an assistant professor at the Alzheimer's Center at the Feinstein Institutes for Medical Research, as well as an assistant professor at the Zucker School of Medicine. Marzena and Luca, welcome to Well Said.
Thanks
for having us. We're very happy to be here.
So let's get started at the very beginning, and I'll ask, maybe we'll start with you, Luca. What is Alzheimer's disease?
Wow, so that is a very broad question, but I think there are a few very set points that we can establish. So Alzheimer's disease is a neurodegenerative disease of the brain, meaning for whatever reason, the brain cells, the neurons in particular, at a certain point in our lives, in patients' lives, start dying off. They degenerate. That's hence the term neurodegenerative. We don't have the full understanding of what causes Alzheimer's disease. We have a few theories, some of them considered more relevant than others, but I think the game is still open on what really causes the disease to trigger and evolve and then cause the clinical symptoms.
It's probably fair to say that many people use the term dementia and the term Alzheimer's disease interchangeably, but they're not the same thing, right? And I wonder, before we get into causes and treatments and stuff like that, I want to just concentrate on the clinical picture of Alzheimer's disease. And maybe, Marzena, could you address whether dementia and Alzheimer's are separate things, or when doctors use those terms, they mean separate things? And if it is different, how is it different?
You're absolutely right. Actually, those terms are very often used interchangeably, and that actually often causes a lot of confusion. It's not uncommon that I hear patients or their caregivers say, mom or dad or whoever was diagnosed with Alzheimer's, but thank goodness he or she doesn't have dementia. So this is often actually something that we generally try to clear up during our patient visits and explain that, in fact, Alzheimer's is one type of disease process that eventually leads to dementia. But there are really many other diseases that can cause dementia or damage to the brain that can become eventually significant enough to cause dementia. And the thing is, dementia is really just a general term for cognitive impairment that has become significant enough to interfere with a person's ability to carry out what we call activities of daily living. And by that we mean things like taking medications, shopping, driving, toileting, even eating, etc. And again, like I stated previously, there's many causes for developing dementia, and Alzheimer's is thought to be the most common cause leading to Alzheimer's type dementia. But there's many other types, including traumatic brain injury can cause enough damage to eventually cause dementia, vascular dementia, where cognitive impairment essentially develops as a result of strokes or vascular damage or injury, or in cases of Lewy body dementia, where there's accumulation of proteins, actually different proteins than in Alzheimer's, and we call these Lewy bodies, which are essentially deposits of different types of protein. But any of these reasons essentially can cause injury to the brain, eventually leading to dementia, and Alzheimer's is just one type of them.
Thank you for clarifying that. And I have a related question, which is the dementia associated with Alzheimer's clinically different from the dementia that occurs in these other conditions?
So it can be, actually. Overall, no matter what the cause for the injury to the brain, the symptoms actually greatly overlap. And they're very similar in many ways, and the symptoms can present very similarly. However, there are some symptoms that are more common in certain types of dementia than others. Again, there's not a clear kind of line where we can say, these symptoms are specific for Alzheimer's disease versus other types of dementia. Alzheimer's disease generally presents kind of in a very insidious, slowly progressive memory loss. Mood changes are also often seen, but again, this is usually a very slowly progressive cognitive changes. Whereas in other types of dementia, for example, dementia with Lewy bodies, patients are more likely to have disturbances in their gait or movement disorders. Patients with frontotemporal type dementias can often present earlier on with emotional instability or labile emotional problems or difficulty with planning. Patients with Parkinson's, for example, Parkinson's-related dementia can present with tremors or shuffling gait, muscle stiffness, and things like that. Even though there are some symptoms that are more likely in certain dementias than others, generally it's not very easy to distinguish just by symptoms alone which type it is.
Luca, you were talking earlier about alluding to the causes of Alzheimer's, and I'm sure that most of our listeners recognize that Alzheimer's is more common in older individuals. But other than age, are there risk factors that have been identified for developing Alzheimer's?
Yes. So as Marzena mentioned, all these neurodegenerative diseases are characterized by accumulations of proteins that should not be clunking up and in some sort of a junkyard type of fashion, but it should be promptly removed from the brain. In Alzheimer's, two of these proteins are amyloid, which is very well known as a term nowadays, and the other one is tau, and they tend to accumulate very, very early in the aging process, probably in our 30s and 40s. So that process eventually comes to a threshold where the symptoms appear because neurons start to die, the connection starts to falter, and the symptoms are evident. But once we see those symptoms of forgetfulness and other symptoms, these proteins have been there accumulating for several decades. So it is very, very important to go back in time, so to say, and ask the patients what kind of symptoms did they present at the onset of disease. That may help us to direct the diagnosis towards Alzheimer's versus other types of dementia. And this is very, very important for us because it is the difference between being able to direct the patients toward a clinical trial or a treatment versus different other strategies to manage the symptoms.
So we'll get to treatment a little bit later, but I just want to dwell on this for another moment in terms of who's more likely to get Alzheimer's. So I understand what you're saying about the accumulation of these proteins in the brain, but why does that happen, and why does it happen to some people and not others?
Yes. So the number one risk factor for Alzheimer's disease is aging, time. These processes start very early, but then they reach a culmination with the aging process after the 60s, the 70s, and the 80s. So the more you age, the more probability you have to have Alzheimer's disease. If you look at the actual numbers, after age 65, probably 0.5, 1%, 5% of the population have Alzheimer's disease. If you go beyond the 80s, you are talking about 10, 20%, depending on the case series, on the statistics. So it is definitely an aging process. Other factors that contribute to the pathology, let's talk about non-genetic factors for a second. Head trauma, cerebrovascular disease, including all the risk factors for cerebrovascular disease, diabetes, hypertension, cholesterol, and so forth. Having a lower cognitive reserve, which means in physiological terms, you can probably liken it to having a lot of connections within neurons. Because what happens during this process is you lose neurons, but if you maintain enough connections, if you have created during your life enough connections between these neurons, the remaining neurons, these can compensate the symptoms much, much better than not. So you may delay the symptom onset if you have a high cognitive reserve. And that comes by being cognitively active during your lifetime. So those are pretty much the non-genetic risk factors. Now, there's a bunch of genetic risk factors that are present. Some of them cause early onset Alzheimer's disease, meaning a familiar, transmissible, genetically determined disease, and it's quite rare. It's only about 1 to 5% of the cases. It's usually early onset in the 40s and the 50s, and it's usually quite fast in progression. There are only three genetic mutations known to do that: amyloid precursor protein, APP, presenilin 1, and presenilin 2. These are three proteins that, if they are mutated, they cause an autosomal dominant disease of Alzheimer's, meaning everybody that has the mutation will have the disease. But these are quite rare. In the most frequent variant, the bread and butter Alzheimer's, there's really no genetic determinants, save from some susceptibility factors. The most famous, the most known of them is called ApoE. It's a protein that serves the function of shuffling junk and lipids in and out of the brain. And one of the variants, it's called a polymorphism of this protein, is less efficient in this job. So you end up accumulating more junk inside of the brain, and that favors the development of Alzheimer's disease.
But it sounds like that the vast majority of Alzheimer's disease cannot be traced to a simple genetic or inherited condition, right? I mean, it sounds like it's more, I don't know, is it fair to say luck of the draw and the other cognitive issues that you raised?
Most Alzheimer's cases are sporadic, meaning there's no familiar evidence of disease. But ApoE, for example, is not a familiar Alzheimer's gene. It's a susceptibility factor. And if patients have a high one or two alleles of this ApoE, they're odds. And again, we're talking about probability.
Okay, so just to simplify the conversation here a little bit, I mean, so you're saying that there are certain individuals who have a greater susceptibility to developing Alzheimer's. It's not a clear cause of the disease, except in very rare instances.
That's correct. And just like Luca said, there's really a lot we still don't know about the disease. But certainly having a family history of Alzheimer's disease does increase one's risk of developing the disease.
Yeah, I'm intrigued by something you said earlier about cognitive reserve and this idea that if you start off, I guess, with a more robust brain or more robust connections between and among the cells of the brain, then you can sort of tolerate more damage without it becoming apparent that you're impaired in some way. So a lot of us are very interested in this subject. Are there things that people can do, sort of brain exercises that people can do that help reduce the risk of developing Alzheimer's?
There's really nothing that has been demonstrated to be better than other things to do, exercises. In general, the idea is that you need to keep your brain challenged. So you need to do things that are out of the comfort zone. They're not easy for you. One element that has been correlated with high cognitive reserve is the fact of speaking different languages and switching back and forth between different languages. And that apparently maintains a degree of plasticity. That's the key word, plasticity amongst the neurons, which creates and dissolves connections, so it keeps the system very dynamic. And that allegedly helps against the neurodegenerative process.
So am I wasting my time by doing the crossword puzzle?
No, I think any activity is better than no activity. But just like Luca mentioned, it's really about doing something new and challenging to the brain. You can kind of compare it to muscle exercise. So if you continue to do the same muscle exercises, for months on end, eventually the muscle becomes kind of bored and it becomes too easy for the muscle, and it doesn't really stimulate any new growth. So anything new, whether it's learning a new language or socializing with new people, thinking of new ideas, and anything essentially to stimulate activity in the brain is helpful.
Now,
and
you mentioned
crossword puzzle. That's great.
Well, you mentioned the sort of analogy of physical activity. I'm curious about what both of you think about physical activity as being something that can help forestall or prevent Alzheimer's disease. What's the data there?
So the data is not great, but I mean, overall, we do know, whether it's from experience or or from literature, that any activity, whether it's physical or cognitive, is important to maintaining function, and that includes cognitive and physical function. One thing to kind of keep in the back of our mind is that Alzheimer's disease or dementia doesn't only affect the brain. It's really a disorder or disease that affects every function of the body, not just cognitive but functional as well. So as much physical functional reserve that we build and maintain, that will be helpful as far as progression of loss of function.
So what I'm hearing is staying active both physically and mentally is a good prescription for reducing the chance of becoming impaired through this process. Would both of you agree with that?
Yes, there is more related to the actual causes of disease and the pathophysiology. So exercise and I put in this big bucket also the leading a healthy life in general will prevent the development of cardiovascular pathologies, including in the brain. Now, cerebrovascular disease, strokes, with all the other risk factors, hypertension, cholesterol, and so forth, these factors in the microenvironment of the brain, they will make Alzheimer's pathology worse. And vice versa. Alzheimer's pathology increases the oxidative milieu of the brain, and it will make cerebrovascular pathology worse. So they feed on each other. So if I take one of the elements down, which is cerebrovascular disease, which is something I can work on by exercising, by leading a healthy life, then I'm acting on Alzheimer's pathology as well. There are also other studies that relate exercise with the production of hormones such as IGF-1, which is in the insulin pathway, signaling pathway, and that has been proven to be beneficial against the accumulation of some of the proteins in Alzheimer's pathology. Now, we're not at the point where we're going to use it. We have a treatment based on that information yet, but it's certainly one area of investigation.
So let me go back to the clinical situation here a little bit. Both of you mentioned memory loss as kind of a early or at least a cardinal feature of Alzheimer's disease. But I think it's also fair to say that most of us feel like our memory declines a little bit as we get older. We have occasional, senior moments, can't find the keys, can't find the right word when we're having a conversation with our spouse or something like that. At what point do you think that people should get a formal evaluation if they're concerned about some of these, what may be pretty common kinds of symptoms? Marzena, let me start with you there.
So you're absolutely right. As we age, there are some kind of, some expected cognitive changes, and including with memory and so forth. But I would say, it's always better to be evaluated earlier than later. If you're evaluated early and it's determined that it's just, age-related changes, then that's great. We monitor and follow up and maybe repeat evaluation after some time. But if we do find something maybe a little bit more than just normal aging, it's often helpful to identify that earlier than later.
And what sort of evaluation do you typically do to make that determination? Is this just talking to the patient? Are there blood tests or imaging studies of the brain? How do you make that determination?
All of the above.
Okay.
So a thorough medical evaluation is very important to evaluate the signs and the symptoms of cognitive impairment, and specifically obtaining a good history, as we mentioned earlier, is crucial. And we often obtain the history from the patient and also collateral information from those who know the patient well and may have perhaps maybe some additional information or something that different than what the patient is able to express. Physical exam also is important to look for clues suggestive of dementia and or the type even. That's helpful. We also do a formal kind of cognitive assessment, whether it's a mini mental status exam or other types of assessments. Sometimes we even do more kind of thorough neuropsychological evaluation when the picture is a little bit unclear, and that's often done by neuropsychologists or neurologists. Blood work also we do routinely just to rule out reversible causes of cognitive impairment, which is definitely something in our differential whenever we do an initial evaluation. And brain imaging also. So we do that because it's helpful to rule out causes for cognitive impairment such as strokes, and even sometimes we find abnormal mass lesions that may explain, whether it's difficulty with word finding or other cognitive impairments, or kind of more specific imaging to identify levels of amyloid in the brain, which can be supportive of diagnosis of Alzheimer's.
Right. So it's a combination of trying to find out if there's something else that might be mimicking Alzheimer's disease and also assessing the level of impairment.
Exactly, yeah. And identifying whether it's something that could potentially be reversible or not, because dementia is not a reversible disease. It's irreversible. And we know that it's a progressive disease, so over time it progresses and becomes more severe. Sometimes when we identify these very mild cognitive impairments, but they continue to stay stable and we have really no concern for any other etiology, sometimes we just kind of wait and see over time.
Yeah, so in the few minutes that we have left, I want to turn to a discussion of treatment. You just said that this is an irreversible progressive disease. That sounds pretty grim. Can you give us just sort of a broad outline of what kind of treatment is available for Alzheimer's? Maybe Luca, we'll start with you.
Yeah, so unfortunately, to date, there have been no demonstrated disease-modifying treatments for Alzheimer's disease. By disease-modifying, what I mean is we give a medication that is proven to stop or revert the pathology. What we have in our hands so far are symptomatic treatments. Many people are familiar with, for example, donepezil or similar medication. These are the so-called cholinesterase inhibitors. What they do is they increase the levels of this neurotransmitter in the brain called acetylcholine, and this creates more activation of the brain as a whole. It's kind of like a doping mechanism, if you will, of the brain. Another medication that is on the market now is an anti-NMDA medication, memantine. It creates less toxicity for the brain by glutamate. That's the intention of the medication, and also activates the brain in a way very similar to the other that I described before. So these again are symptomatic medication. When we give to the patients, we may or may not observe a visible effect in the few months or years after we start the medication. And that's because their effect is really, again, not to stop the disease, but to make the brain work a little better, a little more effort. Now, recently, there has been, about a month ago, the approval of a medication that was touted to be a disease-modifying medication for Alzheimer's, aducanumab, produced by Biogen and, again, approved by FDA at the beginning of June. And this has been a little controversial in the circumstances of the approval and what is surrounding the perceived efficacy as a disease-modifying medication. This medication is an antibody against amyloid. Amyloid is one of the few proteins that accumulate in the brain of Alzheimer's disease. And this medication was shown to reduce the amount of amyloid in the brain by imaging, by PET scan. The PET scan, which is one of the tools that we use to diagnose and eventually follow the course of the disease. And the approval was done in virtue of this piece of information, meaning reducing amyloid in the brain by PET scan. Now, unfortunately, as a scientist, me and many others, and as many clinicians like us, know that this is not nearly enough to say that the medication is effective to curb the pathology, to make it better, improve it, or stop it at all. So the problem with the controversy around this medication and its approval is the fact that when you look at the statistical data that are available, none of them prove efficacy in terms of disease progression. So all we have is the information about the imaging. And unfortunately, this type of imaging is not really reflective of the clinical progression of disease. So that is why this medication has been controversial. So yeah, we don't know if it works or not. We really don't know. We don't have elements to say that it does or it does not work. So we need more data, more information, and Biogen will be required to run more clinical trials to prove clinical efficacy.
So let's just look to the future in the couple of minutes that we have left in terms of what's out there that you think holds promise for treatment of Alzheimer's disease.
Yes. There's a lot. The pipeline is really very, very wide. The one other molecule protein that we focus on in general as a scientific community, and in specific in my lab at Feinstein, is tau. Tau is another protein that accumulates in Alzheimer's disease, and contrarily to amyloid, the amount of tau that is in the brain correlates with the clinical progression. So that is a very good readout of what's happening in the brain and the clinical function. So there are some clinical trials ongoing, and we are experimenting in animals to reduce tau accumulation in the brain. There are some trials that will be closing down at the end of this year by Lilly and other companies. So we're all, very excited to know about those results. Research is moving, basic research and pharmacological research is moving also towards the curbing inflammation in the brain. Inflammation in Alzheimer's is a very relevant element, and it contributes to the progression of disease. So if we can control a certain type of inflammation and microglia activation, that is something that may lead to reducing pathology. And then, as I mentioned, a lot of molecules that are related to the metabolism of insulin and related hormones are in clinical trials. At Feinstein, we have a couple of clinical trials. One will be on the insulin pathway. And there are many other medications in the pipelines related to modulating inflammatory cells, not only microglia, but also other inflammatory cells. And finally, there's, I always speak in terms of Alzheimer's disease as a brain where a lot of junk accumulates in the brain. It's kind of a colorful way to do it, but to describe it. But that's pretty much what happens. A lot of stuff, proteins, accumulate, and they should not. So there's a line of research that is working into improving the efficacy of cells to get rid of junk and destroy it. So that's another innovative area of research that's going on.
Great. Marzena, anything you want to throw in there?
Essentially, the bottom line is, there's a lot of things that are potentially exciting in the pipeline, but as a clinician, I think on the front lines of managing this disease, there really isn't anything yet that I'm getting too excited about.
Yeah.
At this point, yeah.
Well, I think that's probably a sad but good place to end our conversation. Lots of hope for the future, but nothing we can reach for right now that has proven efficacy in changing the natural history of this awful disease. Well, I want to thank you both for joining me today.
Next time we talk, we have some more positive news.
Absolutely. Thank you both.
Absolutely. Thank you for having us.
Thank you so much, Ira, for having us.
For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.